I don't have any conflict of interest to disclose or any interest in conflict. Now, as a clinician and researcher, I think I can criticize both sides of the equation. And to me, as a clinician, I think it is safe to say that brain imaging has overpromised and underperformed when it comes to translation into everyday practice of clinical psychiatry. Now, there's many reasons which block the move of brain imaging to clinical practice. I think the overarching issues here pertain to clinical heterogeneity and the way we analyze these results. And here I would like to focus on the way we analyze the findings. So still the most frequently used methods of brain imaging data analysis are mass univariate techniques, where we treat each individual region of the brain as an independent unit of analysis. If we have many such regions, we have to do many such independent comparisons. These types of analysis are burdened by many statistical issues. They involve the multiple comparisons that leads to effect size inflation, winner scares. We also see a major excess significance bias in the literature, and so on and so forth. Even more importantly, this way of analysis ignores the network architecture of the brain. We're assuming that each region is independent from other regions, which is certainly not true. This type of approach is sensitive to relatively large, relatively localized alterations. So maybe it would work well if you wanted to locate the lesion in Phineas gauge, but it's not going to work well in severe mental illnesses, which are complex brain disorders that are not related to changes in a single region. So effectively, when we're applying these mass univariate analysis, we assume that SMI is an expression of a brain lesion in a brain which is comprised of completely independent regions. Now, if we want to switch our focus to the network level, then we have to switch our analysis to more of the multivariate techniques. These tools model many regions at the same time, so they limit some of the statistical issues that were encountered before. They respect the network architecture of the brain by modeling relationships also between the regions, and they're sensitive to alterations within networks, which is a more relevant unit of analysis when we want to study complex brain disorders such as SMIs. Now, the question is what happens when we apply these multivariate analysis to large data sets? And to answer that question, we paired with the ENIGMA consortium, which is a consortium of people who like to collaborate. ENIGMA provides harmonization of the processing, but not harmonization of the recruitment. There's no centralized recruitment. People can use their legacy data sets that they collected for whatever reason. Now, this is considered by many to be a limitation. I think it is actually an advantage, because this is one way how we can get a highly generalizable snapshot of the conditions we're studying from around the world, which is not constrained to a very specific subpopulation within the illness. So in collaboration with ENIGMA, we collected data from 1,600 controls and over 800 cases. These were people with bipolar disorders. We collected data from 13 countries on 6 continents. I don't want to get into discussion as to which multivariate technique is the best. Suffice it to say that for this analysis, we wanted something that's relatively simple, that's well standardized, easy to use and interpret and compare with previous findings. So we chose the principal component analysis. Now, we previously experimented with clustering, but that does not seem to fit well the type of data that we're getting from people with SMI, where, as you can see from this plot, there is really no distinct clusters in these data. We also didn't want to use machine learning, which is for the most part a black box that's not very well standardized, especially for maybe some of the more cutting-edge variants, which may be more interpretable. So what we did is that we derived cortical thickness and surface area using the ENIGMA harmonized pipelines. We applied principal component analysis to detect the cortical patterns separately for cortical thickness and surface area. We calculated loadings per each ROI to visualize these structural patterns, again separately for cortical thickness and surface area. And then we quantified associations between the first component and system-level predictors, including diagnosis, bipolar disorders versus controls, obesity as measured by body mass index, age, sex, and medication exposure. So what we saw was that there was a very dominant first principal component which explained between 42 to 46% of variance in cortical thickness and surface area respectively. With exception of second component for cortical thickness, all other components explained less than 5% of the variance. Now, all the loadings for the first component for both the CT and SA were all uniformly pointing in one direction. So if a predictor was negatively associated with first component, it would be negatively associated with cortical thickness or surface area across this network, which we visualize based on the loadings. Now, the loadings for PC1 across the regions for cortical thickness and surface area were correlated to a large degree, but not completely. The key question then was, what clinical measures will be linked with these patterns? And what we saw is that in general, we found more system-level correlates for cortical thickness than surface area. Interestingly, for cortical thickness, the same pattern of structural alterations as captured by the PC1 was associated with very different system-level variables, including diagnosis, BMI, age, exposure to lithium, or antipsychotics. While the diagnosis of bipolar disorders, higher BMI, higher age, and antipsychotic exposure were negatively associated with cortical thickness, lithium was positively associated with it. So to summarize the main findings, we saw that many regions across the brain were correlated within and across individuals, hence the dominant first principal component. Across all regions, the associations between cortical thickness and the first component was occurring uniformly in one direction. Now, the same distributed pattern of brain regions as captured by this first component was associated with different system-level variables. While some associations were positive and some were negative, they all occurred within the same brain network. Now, this is the surprising thing that we encountered. We thought that with applying these multivariate techniques, we will achieve a better one-to-one mapping between a specific condition and specific brain signatures. And in fact, that certainly was not the case. And it wasn't the case for many other researchers in this area, where many other studies also show that the same brain patterns are associated with very different disorders, but also with aging and obesity. And I think that's exactly the same as the previous speakers have also found out. So this lack of specificity of neurostructural patterns between and across SMIs and other system-level variables is highly replicated. There is no crisis of replication here. Now, the prevailing interpretation of this pattern is that these non-specific cortical changes across many conditions are related to overlaps among the disorders in genetic underpinning, etiology, neuropathology, or symptoms. But to me as a clinician, I mean, we can argue about that, but bipolar disorders and schizophrenia to me are very different conditions. You may disagree with me, but I think we will all agree that bipolar disorders and obesity, or schizophrenia and obesity, are certainly not the same thing. So that's one issue I have with this interpretation. The other issue is that when we invoke commonalities in genes, etiology, or symptoms, we assume that brain changes are actually causal of these illnesses. And we know that many, if not most, brain changes that we're detecting in people with SMI are actually secondary. They're a consequence of the episodes of the illness, of comorbid conditions, or even treatments. In addition, the prevailing explanation for this non-specific neural P factor, I think, doesn't fit some of the other findings. For example, the loadings for PC1 from people with SMI correlate very closely with loadings across regions of interest from controls. And we looked at this also with Dr. Paus, who sent us his loadings for the first principle component from his charge consortium data set, and our PC1 with his PC1 very strongly correlated between each other. The other underappreciated fact is that the loadings for PC1 across regions from controls correlate very strongly with loadings for PC1 from other controls. So here, when we talk about this non-specific P factor, we're not dealing with something that is common to patients only. This is something that's also shared with controls. So maybe the lack of specificity of links between SMI and brain patterns does not reflect overlaps between different disorders, but rather maybe it reflects common organization of the brain across people regardless of SMI, and it reflects brain plasticity, where brain changes are a consequence of SMIs and they propagate through networks. So, in other words, I'm suggesting that there's a common neuroanatomical pattern of correlated brain regions, which was documented by the fact that we saw such a dominant first principle component, and by the fact that the first principle component correlates between SMI's controls and SMI end controls. So all of these conditions or groups share the same blueprint of the brain. Now, changes in one region are likely to propagate through the network as neurons that fire together wire together. And also perturbations within one network are going to propagate to other networks. Now, this is supported by the fact that the PC1 was uniformly linked with cortical thickness in all regions. So, and the fact that disorders cause uniform decrease of cortical thickness across all of those regions. So if this is the case, then you end up with essentially the same pattern regardless of where the process started. And this would explain why very different predictors are all associated with the same global patterns in the brain. Now, we discussed this with Dr. Paus in quite some detail, and I asked him to try to provide some evidence that would refute this explanation. And he asked about if this is the case, so why would we then see that similarities in the group differences in cortical thickness correlate with genetic similarities across the same disorders? I think this makes good sense that they correlate because the brain changes happen on the same blueprint, which is going to be coded for by the same genes, regardless of the disorders. He also asked why is it that some conditions are more similar than others. And if you look at this, for example, ADHD or autism are less correlated with, for example, mood disorders. And I think, again, that makes good sense. Maybe for these neurodevelopmental disorders, there is a different blueprint to start with. So a blueprint that is not going to correlate with the blueprint that we see in more neurotypical populations or in conditions that onset in or after adolescence. So I will leave it up to you to decide whether you believe that the commonalities that we see across different brain disorders reflect the network organization of the brain and illness-related plasticity, where changes in any region propagate within and between networks, or whether bipolar disorder, schizophrenia, obesity, aging are biologically essentially the same thing, in which case we can abandon the diagnostic system and just call everything brain disorder, not otherwise specified. I'm very interested in findings which would refute this type of interpretation. And I thank you all for your attention. I would like to thank my team for their help with this. So I think we can now move to the questions for all of us, but maybe if you have some question for me first, I'm happy to try to answer that.
Hi, thank you very much for your talk. So your findings suggest that there's similar patterns in cortical thickness and maybe surface area, but when I think about obesity, and I don't know too much about the other disorders, I think of a lot of like abnormalities in subcortical structures or white matter as well, and maybe perhaps that's where we start to see the differentiation across these different disorders that might tell us a little bit more about the behavioral phenotypes. So I just wanted to know what your thoughts were on some of the other properties of the brain and whether or not you think that they would also look very similar.
Mm-hmm. Yes, yes, they do look quite similar as well. We have a separate study where we looked at subcortical structures in people with bipolar disorders and obesity. And there was an overlap between the correlates of obesity and bipolar disorders, even in the subcortical regions of the brain as well.